Oh, one more minute, everybody, and well, maybe a couple minutes just to make sure we get everybody. I got a couple more people coming in right now. It's nice to see we have such a nice big group.
That's a great turnout. Nice to see all your faces. So I think a few more minutes to let some other people join and look forward to getting started.
Yep, got a couple more right now.
Michelle, I learned something about Zoom that might be helpful. When your microphone is muted and you want to speak, just touch the space bar if you're using a laptop or a computer. And then when you let go of the space bar, you go back to mute.
Oh, really? Oh, that is interesting. That's good to know.
Yeah, give it a try. It's very convenient, better than moving the mouse and clicking mute and unmute.
Right. Mine has some controls too that I can mute and unmute right from my computer, because I've got a little bar that has that as well. But not everybody has that. So yeah, everybody have a cup of coffee, have your breakfast or whatever you've got going on this morning. Just about ready to get going. Thank you all for joining us today. This is we've got quite a big group here. It's nice to see that we have so many people on this. I'm going to read off a few things to begin with, and I guess I'll just start that right now. Welcome to this Ask the Doctor morning Zoom discussion with Dr. Matthew Pianko. Dr. Pianko is the Clinical Assistant Professor of Internal Medicine, Division of Hematology Oncology at the Rogel Cancer Center of the University of Michigan Medical School. Dr. Pianko's work is focused on the care of patients with plasma cell disorders such as multiple myeloma, smoldering multiple myeloma, asymptomatic multiple myeloma, and similar disorders. Dr. Pianko is interested in clinical research and development of clinical trials for novel drugs and novel drug combinations for patients with these disorders. Before we begin our discussion, I'd first like to thank our very important partners. Here's my little sign. Can you see it? There. Bristol Myers Squibb, Amgen, Adaptive Biotechnologies, Karyopharm Therapeutics, and Takeda Oncology. Without them, we wouldn't have the resources to reach out to multiple myeloma patients and provide this great discussion platform. So thank you very much for all of you that are on this call. We really, truly appreciate it. I also want to introduce Sid Moss, the founder of Cure Multiple Myeloma Corporation. Sid is the one you can thank for those great Cherry Republic breast baskets. So Sid, do you have a couple words you want to say to the group? Sid? You're not muted.
I am muted or not muted?
You're unmuted. We can hear you.
Oh, okay. I want to thank Dr. Pianko and myself for volunteering and being a vital part of our organization and presenting this morning. So, ready to go.
Okay.
Great. Well, thanks again to Sid and to Mickey and to all of our sponsors for helping organize this great series and for including me again. So it's nice to see all your faces. It's nice to see some faces that aren't hidden behind masks. So it's great that we can continue to have these great discussions, even though times are a little different now than they were last time we had the series. So thank you all for waking up this morning and joining us. So I guess things are quite different and overall, and the care of myeloma as well as anything else interacting with the health system. The whole world's a little quite different right now. But in terms of progress in multiple myeloma research and development of new treatments, there continues to be progress, which is great. Every year we look forward to many of the major medical conferences that happen, both in the summer in Chicago at the American Society of Clinical Oncology Conference, as well as in Europe at the European Hematology Association Conference. And many of these conferences have turned out looking a lot like this call, where everyone is actually sitting behind a computer and looking at people present their new data remotely. So I think that there continues to be new information that's coming out that I think is great for patients. So some updates in many prior talks we've talked about. CAR T cells, I think, is a new therapy that's coming for myeloma patients. It's here in clinical trials, but not outside of clinical trials yet. So it is being used to treat some other types of blood cancers, such as leukemia and lymphoma. The progress for myeloma in CAR T cells, there's some of the major trials have reported some data that continue to show that there are high response rates to these types of treatments. There are still significant. There are side effects that require an inpatient hospitalization and require close monitoring. I think they're getting a better handle on being able to control those side effects, namely one called cytokine release syndrome. And so this is the most common side effect that people get with CAR T cells, and it can involve fevers, chills, low blood pressure. And in a way, it's the immune system reacting against the CAR T cells are sort of an immune treatment. So in a way, that it's a sign that the immune system is reacting against the myeloma. And with early recognition of these side effects, we do have an antidote of sorts that can be given to sort of calm the immune system and lead to these treatments to be delivered in a more safe way. But still, I think looking ahead, it's not something yet that's FDA approved. There had been hopes that FDA approval would come earlier this year. I think the FDA wanted to get some more information from Bristol Myers Squibb, who's got the lead the lead candidate that's probably the most likely to be approved first. But we're still looking forward to hopefully being able to offer that option to patients. We do have some study. We have a study of CAR T cells going on at U of M. We are about to start opening up and enrolling patients again for that. So that is looking for patients who've had prior treatment with the drug Darzalex or daratumumab, essentially, I think if you have more questions about that, we'd be happy to give you some information about that. What BCMA is, which is what the CAR T, it's a protein the CAR T cells go after, is actually being looked at by a number of different drug companies who have exciting compounds that are in clinical trials that are hopefully going to be coming soon to patients. So there's various ways of targeting this protein. With people are developing IV treatments that can be given that require less of the coordination to give than the CAR T cells require. One of them is called belantamab. That's a drug that is being developed by GSK. And so this drug can be given subcutaneously, or I'm sorry, IV, and it can be something that we could pull off the shelf. It doesn't require a lot of manufacturing. So I think that we're looking ahead toward, I think these agents are some of the more likely to be FDA approved as new drugs for myeloma, I think within the next year or so. There are other drug candidates and clinical trials that also go after this same target, and we have several of those at U of M. This is an area of intense interest, and the reason it's interesting for myeloma is that this protein is really present only on plasma cells, on the myeloma tumor cells, and it's not really anywhere else. So it makes an ideal protein target to go after if you're going to get rid of any cell that has a protein. For treatment of myeloma, you'd hope that that protein is only on myeloma cells, and that's why I think there's so much interest in going after this BCMA drug. So, there's a number of different, efforts that we were working on at U of M to explore this as a target. I think it's an area of much excitement, both here at U of M and really at many sites around the world. I think that the whole COVID outbreak has led to, at our center as well as others, for much of our clinical research to shut down. So patients who were on trials, were able to continue getting their treatments on the trials, but new enrollments were halted for a while, and are now opening back up. Which is very exciting. I think that we found that reorganizing the way the cancer center is organized to allow for maximum safe social distancing, and for trying to limit the amount of people that are coming into the clinic at the same time, has allowed for operations to resume in a new way, and things are we're still all I think adjusting to all this, but I think that I was very pleased that U of M was very proactive in reorganizing and sort of shutting down when they needed to shutting down what they needed to shut down, and reorganizing in such a way to make it safe to be in the medical center and safe to get treatment. So. I think that in a large way, the clinical trials, opening back up is a great sign. I think we're also in the process of getting new trials that are coming, and I don't see COVID really interfering too much with that. So I wanted to just pause to maybe give some of you a chance to ask any questions. I think that if there's an area of specific interest, I'd love to talk about a question. So please feel free to either to unmute, or if you click in the bottom of the screen, there's the chat button. That's also a good way to type in your question really at any time during the call. And we can, see what's in the chat box and respond to your question. So, if any questions here at the outset.
So I have a few questions that were sent in prior to this. Would you like me to go through those right now?
Sure.
Okay.
Yeah.
All right. So the first one is, are you familiar with any connection between vasculitis and any of the cancers that you're studying, or for that matter, any cancers?
So vasculitis, which is defined as inflammation of the blood vessels, either the arteries or the veins, is something that is conditions that are seen in autoimmune disorders. So there are several autoimmune disorders that can cause this. Lupus. There's a more rare type of vasculitis that is caused by a disease called Behçet syndrome. These, in terms of the malignancy association with vasculitis. So, we do see a number of patients in our clinic who have autoimmune disorders and have either MGUS, which is the precursor condition to myeloma. But I can't say that I see a significant degree of vasculitis in our myeloma patients usually. I think that where one can see vasculitis in this group of disorders. So Waldenstrom's macroglobulinemia is a condition that's a B-cell lymphoma. that makes a type of monoclonal protein called IgM. It's different than most myelomas make a different type of monoclonal protein, but these groups of disorders are somewhat related in a similar family of diseases because they come from a similar type of cell. So this IgM protein, it's a big protein. It's very sticky. Sometimes these can be called, there can be types of IgMs that are called cryoglobulins, which tend to stick together. And the word cryo is in the name. So, association with cold weather, sometimes these are proteins that become more sticky when it's cold out and if someone has this type of condition. These cryoglobulins, when they get sticky, can kind of clog up the blood vessels and lead to inflammation in the blood vessels. So indirectly, there can be a cryoglobulin-related vasculitis. I can't say that we see it very commonly. I think that if, I was seeing a patient who had myeloma, was undergoing treatment, and, we encountered an issue with a type of vasculitis, I really would be questioning whether those are related or whether there is an underlying autoimmune disorder that's present.
So the second part of that question is, and you kind of went over this already, but also the development of arthritis, either psoriatic or idiopathic, and its relationship to these types of cancers. Oh, wait a minute. I didn't unmute.
Oh, you did. You did. Yeah, I heard that. Thank you. I think there's a really interesting interplays between the immune system and plasma cell disorders. So, plasma cells are these cells that, part of their normal job in life is to respond to inflammation and infection. If we get a virus or we get a bacterial infection and our body fights it off and our body has an interest in not having us get the same infection again. These plasma cells and B cells respond to those that type of inflammation and can be stimulated by it. So I think there's some, we do see that patients who have autoimmune conditions like psoriatic arthritis or lupus, so their immune systems are kind of always stimulated in a way because they're reacting against themselves. And so we do find that in these patients, when testing is done for looking for monoclonal proteins, so they might have elevated immunoglobulin proteins and a test might be sent to look for a monoclonal protein, is that we do find a fair amount of them patients who may have the autoimmune condition and one of these types of disorders. So I think there's some, theoretical overlap. We do see higher amounts of patients with autoimmune disorders. There's a relationship with MGUS and myeloma. We see more patients with autoimmune disorders get these conditions when compared with the general population who doesn't have an autoimmune condition. So from an epidemiologic standpoint, this has been an observation. And the way that I think about it is if the immune system is always revved up and fighting itself in some way, and those plasma cells are always stimulated, when you have types of cells that are constantly stimulated all the time, there's the possibility of developing cancers in these types of situations. I think the risk is generally, we always see these patients and evaluate them and really try to figure out, is there really the malignant condition present, or is it truly the precursor condition, MGUS or smoldering myeloma? We do have, patients who we would just end up watching very closely, many patients who don't have myeloma but are found to have these precursor conditions. So, I think that it's the connection is due to the fact that, these plasma cells, they're very responsive to the immune stimuli. They're responsive to the signals our immune system uses to send messages. And if the immune system is always constantly on guard and those cells are always revved up, whenever any cell copies its DNA, if you think about it a little bit like copying a book, every time a book is copied, there's the chance that there's a typo that gets entered into a certain chapter. So if you're always copying the book over years and years and years, you might get more and more typos. And so if the immune system is activated and these cells are more active, potentially dividing more, it introduces just from a random chance probability perspective that over a course of years that there might be more of a chance that these patients with autoimmune conditions could end up getting myeloma.
So is there anything that patients can do to help autoimmune, to guard against that, or to make their immune system more stable?
I think that's it's a good question. I think that relevant to the particular type of autoimmune condition, we don't think about treating specifically to reduce the risk of these precursor conditions turning into myeloma someday. We usually suggest that really the treatment be directed at trying to best control the autoimmune condition and limit the damage that the autoimmune condition is causing the particular patient. So I think it's worth a discussion with the rheumatologist who's managing the autoimmune condition, and to think about which types of treatments to choose. There are certain types of so that it's a little bit of a double-edged sword. So our bodies use the immune system to patrol and monitor for new cancer cells that pop up, and we actually eliminate cancerous cells all the time. And so in part, for treating autoimmune conditions, if you're suppressing the immune system with certain types of autoimmune treatments, there can be increased risk of cancer use to treat autoimmune conditions. So in a way, you think about, well, I want to calm my immune system down and have less like constant inflammation that might be driving something to happen. But in a way, the tools we use aren't specific enough yet, or I think that in a way, sometimes by treating the autoimmune condition, there has been some increase in lymphomas, particularly. I don't know that we've really seen that with myeloma. It's more an observation with lymphomas rather than myeloma. But it's sort of a long answer to the question, but it's complicated.
Okay. I want to encourage everyone to type any questions in the chat button. I do have a few more questions here that we can go through, but if there's anything that you want to ask that's related to whatever we're talking about, either do that or on a computer. I'm not sure exactly where this is on, like on an iPad or a laptop, or a phone, but there's also an area that's called More, and you can raise your hand if you have a question too. So please feel free to do that, or just unmute and ask your question. I ask you all to keep muted most of the time, just because there are external noises in everyone's house, and we don't want to have that interfere with what's going on with the rest of the group. But I do have another question here. This question is how to prevent, let's see, another question is how prevalent is it for MGUS, smoldering myeloma, etc., to develop into full-blown myeloma, and if it differs in presentation somehow once that development becomes apparent?
So in general, it's a good question. So the MGUS, which is an acronym that stands for monoclonal gammopathy of undetermined significance, or the condition where we find an extra antibody, a monoclonal protein in the blood, and really I like to say that, monoclonal gammopathy of undetermined significance, in plain English is there's an extra protein there. We're not sure if it means anything. These patients have a low, overall a low risk of progression to myeloma. Roughly average on the order of about 1% of these patients per year. It's actually quite common if you look in the general population for adults over 50. Looking at studies that have gone out into the general population and drawn blood from people, large amounts of people, namely, there's a big study out of Mayo Clinic that they surveyed some 30,000 people in the county around Mayo Clinic and followed them for years. And from that information, we're able to actually say and understand for those patients with MGUS, what is the risk over years? And so that work was led by Dr. Bob Kyle, and he's 94. He still lectures and writes actively, and his work is the basis for being able to really answer this question. So it's about 1% per year on average for most MGUS patients. It can be, usually what we'll do is look at patients' laboratory results and help sort them into risk categories. Looking at the size of the M protein, if the size of the M protein is 1.5 or greater, that's a risk feature. If it's an IgA or IgM monoclonal protein, that's a risk feature. And if the test, the serum free light chain test, which is another test looking at proteins made by these types of cells, if there's a value we get from that test called the kappa lambda ratio, if that is abnormal, that is also a risk feature. Practically how we use this in the clinic is with low risk MGUS, meaning if they have like an IgG protein and it's small and they have a normal free light chain ratio. These patients, we would talk about, really the option of doing a bone marrow or not. Really the value of a bone marrow biopsy is to understand in the bone marrow how many plasma cells there are. And when you know how many plasma cells there are in the bone marrow, that number provides basis for sorting patients into a diagnosis of either MGUS, which is the lower risk precursor to myeloma, or smoldering myeloma, which is the higher risk condition for progressing to myeloma. So, MGUS, if you think about, it's 3% of the population over 50, and it goes up with age, it's, up to, 7% over age 70. If you just think about how many people there's a lot of people walking around with MGUS who may or may not know it. So, we think overall the risk is low, and currently there's not any interventions that we know about that can make that risk, any lower. So we usually suggest people to, try to have a healthy diet, exercise, try to just stay active. But, apart from that, there's not any sort of dietary or supplements that are really recognized to reduce the risk of MGUS turning into either smoldering myeloma or active myeloma. So to speak to a little bit to smoldering myeloma, so really the arbitrary cutoff where we think MGUS ends and smoldering myeloma starts is with a bone marrow plasma cell percentage of 10% or more. I sometimes, many times meet with patients and they'll have their number comes back and it's 10%. And so then, we have a discussion that is saying, well, although you're on the fine line between MGUS and smoldering myeloma, what really do I have? Is 11% really fundamentally different than like 8%? I think we still just end up, erring on the side of caution and watching closely, but that's often a discussion I have in clinic is well, I'm right on the line. What really do you call what I have? I think that some updates last year really about So I mentioned the risk system for assessing MGUS. We have a similar risk system for, actually there are several systems for helping sort out who has high risk smoldering multiple myeloma. And this is an area in which clinical trials are being done, or for those patients who have the highest risk of progressing to myeloma. And so we look at, also at the labs, we'll look at an M protein of 2 or greater, free light chain ratio of 20 or greater, or a bone marrow plasma cell percentage of greater than 20%. Each of those are the risk features. That's one system that was recently updated. And I'd say that there's interest in trying to see, for those patients with the highest risk myeloma in whom the risk of actually progressing to get the disease is 50% or greater in 2 years, roughly. This is an area in which we are really trying to think of, well, if it's a flip of a coin of whether or not someone's going to get the active disease within a year or two, within 2 years or so. Really this is an area where we have a discussion about, well, what could we do in this situation? If the risk is 1% per year, it's hard to imagine a treatment being worthwhile if a treatment might have side effects to try to reduce 1% lower in the MGUS scenario. But if looking at 45%, 50%, these are situations in which we really, it's an area of interest in trying to see if there's anything we can do to try to change that. So there's been several trials in this area, and there's several that are ongoing now looking at using some active myeloma drugs for active myeloma in the smoldering scenario. There's a large study that we're running, or that we're part of at U of M, called the DETER SMM study. And so this is a trial that looks at exploring daratumumab plus Revlimid and dexamethasone versus Revlimid and dexamethasone. It's a 2-year course of treatment, and then treatment is stopped and patients are observed after that time point. And the hope is that we can look to see if we can really prevent smoldering myeloma from turning into active myeloma. I think that what interests me, I wish I could speak that I had a clinical trial in this area to tell you about, that I was, that is part of my deep interest, but is, if we could really, try to create some sort of vaccine where, your body begins to recognize the myeloma cells, the smoldering myeloma cells, as foreign and mounts a long-lasting immune response, I think that would be fascinating to be able to develop. There are some studies that are, looking at this, but partly many of the, to date, I think haven't had success with that approach yet. And mostly the trials in this area are looking at using myeloma drugs earlier. This would be something that would really depend on the area that you're being treated, if there'd be anything in this, with this sort of approach to treat smoldering myeloma. I think that there's interest in this, but I think finding trials that explore this they're not really very commonly found yet. So I talked about the highest risk myeloma. I think, we estimate the risk is, around, 45, 50% of the high risk myeloma of a risk of progression in 2 years. If we get down into the lower risk categories, typically overall what we've said is that so these patients who get smoldering myeloma, who we do their bone marrow, and we find that they have, more than 10%, but less than 60%, because that would be the marker for active myeloma. Those patients with smoldering myeloma as a whole, in the lower risk groups, probably have about a 10% per year risk of myeloma for the first 5 years. And then after that time point, after about 5 years, we find that actually the risk drops off. So, biologically, I think that what that means to me is that, when we find more than 10% plasma cells, there's some patients whose plasma cells are going to act like myeloma, but they just don't have enough myeloma cells yet to be called myeloma, or the myeloma cells haven't caused damage yet. And there's a group of those patients with more than 10% plasma cells who act much more like MGUS, in whom those cells really don't grow, they don't do anything. The immune system maybe keeps them in check for years. We don't totally understand all the reasons why MGUS or smoldering myeloma would progress or not. But likely there's an element of the immune system maintaining some control, as well as possible genetic changes in those cells over years that could turn MGUS or smoldering into active myeloma. So, I think that in a way, the question about what's the risk of progression in smoldering patients, it depends on the risk scores, on what we think that what category of risk the patient falls into, and at the end of the day, time is so helpful in understanding what the risk is. If someone has had 5 years of smoldering myeloma or 6 years of smoldering myeloma and something hasn't happened yet, looking at the big studies that have happened in that condition, we think that after that 5-year time point that there's much less likelihood that it's going to progress. So it goes down to maybe 3 to 5% per year.
That's good. So we have Linda Phillips has her hand up and has a question. So I was just going to ask her to unmute and ask her question.
Oh my, I would so give a lot to have my mind back, because I can't remember what it was.
That's okay. If it comes to mind again, feel free to raise your hand or just type it into the group chat with the button at the bottom of the screen.
Thank you.
No problem. No problem. So I have a question that came through my chat about the use of MRD testing. So I give a little bit of background on what MRD testing is. So there are, last 15 years or so have brought many advances in multiple myeloma, and to that effect, we've been able to achieve much deeper responses to the treatments. So the question, so what has happened is that the ways that we measure the activity of the disease through blood testing with protein electrophoresis or serum-free light chains has a limit of detection. And so someone might be diagnosed with myeloma, get their treatments, and ultimately the proteins that were found in the blood that were a source of a sign that the myeloma cells were there, that disappears. That can disappear if someone's having a really great response to their myeloma treatment. And so if we then do a bone marrow biopsy to see how many cells are left over from the myeloma, let's say someone gets their initial treatments, they're just starting out, they're thinking about going to transplant, they get their bone marrow before they do their transplant. If there's not visible plasma cells that are present on the biopsy, there are some new tools that have been developed to find minuscule trace amounts of myeloma cells that are left over. And this is a new way of assessing how deep of a response people are getting to their myeloma treatment. So there are usually two tools that can be used. There's a company, Adaptive Biotechnologies, which is one of the sponsors for this event, who has a test called clonoSEQ, in which the bone marrow biopsy specimen, the liquid bone marrow biopsy specimen that's done at the time of trying to assess the response. The liquid bone marrow biopsy specimen can be sent to the company, and they will both take the patient's initial bone marrow biopsy specimen as well as the one after treatment and look for a genetic fingerprint of the myeloma cells in the post-treatment bone marrow, looking to see, even if all the tests are normal, is there any detectable myeloma left over? So this is, it's a test that's been, cleared by the FDA. Some insurance companies are paying for this. Overall, I think it's a tool that's being more available to us. I think the question is what to do with this information. So I think that there are several clinical trials that are looking to say, maybe for patients who they did their upfront treatments, they did their transplant, they're coming back from transplant, to say, well, doc, I did all of the 3-drug treatment and I did the transplant, and now we're thinking about starting maintenance. There might be to say, well, if you're MRD positive, maybe we think about doing some more treatment before moving to maintenance. That's a clinical trial question. I think that the reason there's interest in this area is that in big clinical trials where they did this type of testing for patients who had excellent responses to myeloma treatment, they found that the people who are MRD negative had better prognosis. The challenge is now is saying, well, that was an observation on a trial that happened, but in real time, how do we use this test? Do we alter treatment based on the results of this test? I would say that there's not consensus in the myeloma community on making treatment decisions based on MRD testing. However, this test can be helpful in an in-depth discussion with your doctor, looking at the data that's available to say, is there any way that this information could help us make a decision? I think another neat idea that's been used, that MRD testing has been used for, that from which we don't have results yet, is to say, well, so imagine the myeloma patient who and they've been on maintenance for years, and their protein numbers have been normal for years, and they have some Revlimid-related side effects. I think an idea that hasn't been tested or fully evaluated, but is an interesting idea, is to say, well, given the issues with being on Revlimid for so long, maybe people have loose stools, or they have a little rash that they've been dealing with for a long time that's needed suppression. Maybe we could get off Revlimid. What if if the myeloma has been completely knocked out and there's no detectable traces of myeloma cells, and we use the most sensitive tools that we have available with MRD testing, if the myeloma is undetectable, do I need to still be on maintenance? So far, I'd say the answer still is yes. We still are recommending maintenance for patients, indefinite lenalidomide maintenance for patients who are after transplant is the general recommendation. But I think that these new tools are exciting in that they'll allow us to get a better handle on, maybe identifying a subset of people in whom therapy could eventually be de-escalated. But I would caution that I think that really the best way to get this type of information is in a clinical trial. I think that the testing can be useful in having an informed discussion with your treating physician about really what can I do with this information. But at the end of the day, I think it's exciting that we're getting these new tools that can detect myeloma at even lower levels than we've ever been able to detect before. Actually, the decisions that we make of putting that sort of information into practice, making a treatment decision between option A or option B, there's still more information that we need to get for that to be regular practice. So I'd say there's not consensus on best use of these tests in myeloma among myeloma specialists, but it's an area of high interest and high debate, lots of interest and debate. So, I want to say it, most of the medical conferences that I go to that, have a strong myeloma emphasis, there's often a panel discussion of pros and cons of MRD testing. You'll have someone who's in favor of using it, and you'll have another doctor who's not in favor of using it, saying we need more information.
So I do have a few more questions here that came in earlier. And I'm really bad at these names of these drugs, and you all know them much better than me. Is daratumumab in pill form yet? And if so, have you been taking it if you've been taking it by infusion, can you switch over to the pill without any problems?
Great question. So daratumumab or Darzalex is an IV treatment that's a monoclonal antibody drug. So in a way that it's a drug that targets a protein on the surface of the myeloma cells called CD38. It has worked its way into many phases of myeloma treatment, and it has been approved in some situations to be included in the first sets of drugs that myeloma patients get if they're not eligible for transplant. It is an option now. It pairs well with many of the other myeloma drugs. The major, problem in my mind with daratumumab has been it just takes so long to infuse. So because infusion reactions are very common with this drug, we tend, when starting it, to give it over a very long period of time. Ultimately, it starts out at 8 hours. We can get it down to an hour and a half infusion with supportive medicines after about the third or fourth infusion, but still, that involves a lot of sitting in a chair time waiting for your infusion to end. So I think it's a great question to ask if Darzalex could be given in oral form or in a more convenient form. I've very exciting news that the FDA had approved a version of daratumumab that is administered subcutaneously. So the drug has a little bit of it's sort of a type of gel that holds the drug, and that can be injected underneath the skin. So this is something that reduces an hour and a half infusion time to about a 5-minute subcutaneous injection. So really an amazing development in terms of just reducing the amount of time that people need to be in a chair getting their Darzalex. So we're in the period of time after FDA approval and before we've really been able to implement that in the clinic. So our pharmacy team is working hard to get the drug and create the infrastructure to store it and safely deliver it. But I'm hoping in some upcoming months to be able to offer that to our patients who are looking for a more convenient way of getting their daratumumab. It looks and it was approved on the basis of several trials that have found really no difference in effect between the IV version and the subcutaneous version. So it'd be great if it was an oral form that we could ship to your house so you could take it home. Unfortunately, that's not something we've really been able to figure out how to do with these monoclonal antibody drugs. But I think that the subcutaneous version is a significant development.
Again, I do have a couple more questions here.
Okay.
Regarding COVID-19, do you have recommendations on tests to take? Are there ones we should avoid or ones we should take if we have multiple myeloma? If you're asymptomatic, how often should you have a test? Should you have it?
It's a good question. I think that we're still trying to learn about how to deal with this in the clinic. So antibody testing has recently become available. I think we're still testing symptomatic individuals. I don't know that there's been really a program to go and expansively test everybody. That's been that sort of program hasn't been available. I think if someone has had an exposure or suspects they've had an exposure, antibody testing can be done to see if you've developed immunity to the SARS-2, the COVID-19 virus. In practice, we haven't routinely been testing or started doing that. We have the tests available, but in terms of deciding in mass to be able to test everybody, I think that we are just being able to have the capacity to be able to offer the tests in situations where we know and think that there's been an exposure. Of course, like in an ideal scenario, I think everybody should just get tested, but to know what your status is. But I think that the limitation is that I think that we are, we suspect that the antibody test, if you're positive for the antibody test, meaning that you've had a prior infection that you've cleared, we think that those antibodies are protective, but are not 100% certain about that. So it's hard to know because this is such a new phenomenon. If that test being positive would mean that you're permanently immune to it. We hope so. And we think about that being the rule for, many other types of infections that we get, is like once you get a positive antibody to it, that you're immune for that, from that type of virus. So I just think this is so new that we don't totally understand yet how this all behaves. So it's a complicated question. I think that anytime you're going out to get testing, you're sort of being outside of your home, and I think that if you're regularly going in to get testing, it is something you could talk to your doctor about to see what they think. I have tested patients of mine who I thought had prior infections, meaning they had had a flu-like illness earlier in the year, and their flu swab was negative, or they had a known family member who was infected. That's been the area where I've been using it. I think that really this antibody test is something we just got access to, so I think the best way to use it yet hasn't been widely adopted. I think that ideally we would just have test everybody and know, like many other countries have done, really had widespread testing availability. That isn't something that unfortunately we've really had here. But U of M does have testing. We do have availability to do it. I think that it's still in a case-by-case basis, where if your physician thinks it's worthwhile, then I think the test can be ordered. But I would say this is an area where the rules change week by week. So next week there could be a program. I just it seems like there's so many developments with COVID that have upended everything, that we're trying to rapidly adapt our system in a way to utilize these new tests and in a way to try to react to the outbreak.
So we do have a question from Linda Phillips in the chat box too now.
Okay. Oh, I see that. Yeah. So it says, with oral daratumumab, would pre-meds still be required? So I just wanted to rephrase. So it would be subcutaneous injectable daratumumab. So my understanding is that there still would be pre-meds that are required. There still is a capacity for infusion reaction. So I think the actual infusion time is less, but there still would be a need for some pre-medications. Sorry, my cat has wandered into my home office. I need to evict the cat. Excuse me for a moment.
I was just afraid that my dog would come in here and start barking any minute, but that hasn't happened so far. I do have another question up here from before. Can you provide us with the latest news on maintenance therapies? Right now, the person that asked this is on Revlimid, 10 milligrams, but if it fails to keep myeloma under control, what's next? Are there other maintenance therapies that are on the horizon, or?
Yeah, so it's a good question. I think that Revlimid maintenance is still the standard choice for most myeloma patients for their maintenance treatments. I think that in general the practice is if the Revlimid maintenance does not keep the myeloma in check after a period of time, that we move on to really back to a more active phase of treatment rather than switching to a different type of maintenance drug. So in general, I would, and everyone's, treatment history might be a little bit different, but I'd end up talking with your doctor about, what you've previously had and, what would be next. In many cases, we would switch to a regimen that doesn't include Revlimid and might include some new drugs that your myeloma hasn't seen yet. I think that it's often can be a complex scenario. So I think that there are patients who can be on Revlimid maintenance in whom their myeloma proteins can climb up over time very, very slowly, and there may not be a need to immediately change the plan. There can be, sometimes patients who for, even a year could be watched still on the Revlimid maintenance. It's often a judgment call, trying to assess how rapidly is the myeloma number going up? If there are, let's say, particular features about a person's disease, like either they don't, have much myeloma protein, or they had an issue where they don't have detectable myeloma proteins, or they had a very a high-risk type of myeloma, and it was very aggressive at the outset. And so I think that all of these factors play into the decision of when's the right time to move from Revlimid maintenance to something else. But in general, the plan would be not to move from Revlimid maintenance to a different maintenance, but to move to another multiple drug type of myeloma regimen. And then potentially there could be a maintenance-like approach that could develop out of that regimen, but usually there would be a period of more active treatment trying to get the myeloma back under control. Hopefully that answered your question. I think that to add one more point, for patients who are intolerant of lenalidomide, there's also been some new data suggesting that the oral proteasome inhibitor ixazomib, or Ninlaro, could be an alternate type of maintenance. We have in some patients used Velcade on a maintenance schedule, like every Velcade injection every other week, with recent data suggesting that Ninlaro could be a maintenance drug in patients who maybe have a Revlimid allergy or some reason why they couldn't do Revlimid. Ninlaro could be another type of maintenance approach, but the scenario of already being on Revlimid and tolerating Revlimid fine, and if the Revlimid just stops working and fails to control the myeloma, we would switch to other drugs. But to add that there are other maintenance type drugs that can be used, but typically Revlimid is still our first choice for maintenance.
So we have just a couple more minutes. If anyone here in the audience has anything that they want to add, please just unmute yourself and ask a question, because we've got some valuable time here, just a couple of minutes. So speak up now, okay? David?
I'll ask a question. What is, Matt, your experience with your myeloma patients, both getting COVID and recovery? Is it different than the general population? And if they get it, how have they recovered?
So it's a great question. So for my patients, I really have had just a small number of patients who had a sick family member who had a known positive contact who ended up having it, and so they really went to the ER with fevers. We were able to manage with Tylenol at home. There was somebody who was getting daratumumab, Revlimid, and dexamethasone treatments. So ultimately we ended up holding their daratumumab treatment and really holding their myeloma treatment. they ended up recovering fine. They didn't ever get hospitalized. They were able to recover. So I really have at this point, thankfully, I would say a limited experience from my patients. The patients that I've had have recovered fine. They haven't required inpatient hospitalization. Nobody's required a ventilator. Everyone has had really mild presentation. And that patient, so there was a patient who did get antibody testing that ended up being positive after the fact, even though they had myeloma and they're on daratumumab. So they were able to make an antibody. So I think that's another question is if the immune system in myeloma patients, our ability to generate normal antibodies is impaired because of myeloma being a tumor of the cells who normally have that function, then I think there's questions about whether or not myeloma patients would mount immunity. So, I mean, it does seem that this patient, recovered well and, made an antibody. So, the hope is that, that person would be immune and, not get it again. I think that, obviously this is a part that, makes me and all my patients very anxious about the current environment. And so I think that we just want to, we can't hope for, a vaccine any sooner. I think then, really just having as much caution as possible. Granted, I know that could be potentially, a year or even more away from what I'm hearing. I think that we're all still going to try to operate with maximum caution between now and when, I think things can be somewhat back to normal. But, I would just try to, use your common sense as myeloma patients to, try to, limit your contact as much as you can. And I know it's just a really long, a long prospect of having to be, changing our behavior like this in a way that's, really isolating. So, I think I'm also getting a lot of questions of, what kind of activity should I do? What can I do? Really, I try to, it's a little bit about, trying to use your common sense about what you should do or should not do. I think, trying to, be careful and limit your exposure to others is important. But it's often really hard to give specific recommendations about what to do or what not to do. So I'm sorry if I add a little bit more to the end to that question, but that's a question I've just been getting every day. So.
I'm sure you have. This is something that's on everyone's mind, how to deal with the current situation, especially when people have an underlying condition. And actually, we are over our time right now. So I want to just say thank you to you so much thank you to everyone for coming together and doing this. And certainly thank you to Dr. Pianko for taking up all this time to be able to answer questions and to talk frankly with everyone. This is a good format. I hope you all enjoyed this. I did. I think that we can all find this very, very interesting. And I hope to see you soon. And again, thank you to our sponsors, Amgen, Bristol Myers Squibb, Takeda Oncology, Adaptive Biotechnologies, and Karyopharm Therapeutics. We appreciate it and hope to see you all again soon. And with that, if there's nothing else, we'll just end this talk. Thank you, Dr. Pianko.
Thank you to everybody, and hopefully look forward to doing this again at some point in the future. And love to entertain any of your questions. So I think if you have any other questions for me, I think you guys could get in touch with Mickey and you can connect me that way. And look forward to the next time I get to see all your faces. And everybody enjoy your summer and stay safe and stay healthy. And look forward to seeing you guys again in the future.
Thank you.
Take
Thank
care,
you.
everyone.
Take care. Bye.
Bye.